Assalamu alaikum. Welcome everyone on board. Before we start, if anyone has got any questions. Okay. Actually, today I just want to discuss some basic concepts about regional anesthesia. Am I audible to you? Am I audible to you people?
Yes, sir. Yes, sir.
Okay. So actually, I just want to share some basic concepts and basic knowledge which you should be knowing before doing any regional anesthesia. This is not only related to safety, the technique, the prerequisites, okay, and like anticipating any complications, and the like equipment, and basic any requirement of related. There will be a number of concerns which will be related to a specific block, whether it is analgesic versus anesthetic, and whether it is giving for any acute setting or some chronic pain therapies or something like that. Okay, so just before we there will be some concerns related to the you can say the age group which we are targeting. Okay, like if we have an elderly patient, we should be considering about the concerns which may be there. And if you have neonate or a pediatric patient, you should be considering things according to that state. If you have obese patient or pregnant patient, there will be some reduction in doses. So like for instance, if you have a neonate and you give regional anesthesia like spinal or epidural, the sign will be hypoxia rather than cardiac symptoms. Just a second. Okay, so you should be the first thing which you will be considering the to the the patient age group which you are targeting. Then in addition to all the resuscitative equipment, okay, you should be ready for extra thing which will be should never be missing is intralipid. Okay, this is one thing. Then what basic pharmacology of local anesthetic you should be knowing, because the things which are important is how to get the onset, how to get the duration of action, how to get the preventing the toxicity. Okay, and if you are putting any adjuncts. Okay, so if we consider these 3-4 things to start with, if anyone wants to speak out, please raise the hand. Onset, which factor of local anesthetic will be related to the onset? What factor of local anesthetic will determine the onset of action, that is pKa. Okay, as nearer the pK is towards pH, body pH, the as faster will be the onset of action. So that's why lidocaine, whose pK is around 7.7, in some books 7.8, will be faster than 8.1 for bupivacaine. Okay, so this is the reason for it. Duration of action is usually with the protein binding. So bupivacaine is longer acting because it has more protein binding than lidocaine. Okay, then there is something related to it, is provision of this addition of vasoconstrictor. Okay, vasoconstrictor not only slightly prolong the action, but it is decreasing the absorption, so it will decrease the chances of toxicity. Okay, similarly, if you want to enhance the pH, like fasten up the effect of that medication, you can add some bicarb. Okay, usually this is another concept, that the preparations which are available are acidic. So anyone wants to speak out, please? Again, because it is better if you people interact. These preparations are usually, if you see, just try to recall, it is bupicaine hydrochloride, lidocaine hydrochloride. Do anyone know why this is acidic? Because to increase
the shelf life of that, because
okay, it is to increase the shelf life. So that's why if we add some bicarb, this will increase the pH of solution. Okay, and it will make it towards the pK. So if you want to fasten up the effect of local anesthetic, you can add some bicarb. Vasoconstrictor. Okay, and then if you because the toxic blood levels are important for the toxicity, so that's why if you are putting it in intercostal space, then for example femoral nerve block, the absorption is higher at intercostal. Okay, if someone can just Jamil, if you can just recall, after IV in IM, what is the most absorbed place for absorption?
intercostal, sir.
Intercostal. Okay, then this epidural, caudal.
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 Epidural, caudal. Yes.
Epidural, and then rest of the gum. So remember one thing, this is a question in MCQs as well. The intercostals, there are highest incidence of achieving the toxic blood levels. So this is important with regard the site. Like for example,
इंटरकॉस्टल के बाद ट्रेकियल में आएगा.
I'm sorry.
ट्रेकियल.
Yes,
Intercostal
yes, you're right.
tracheal.
Yes, tracheal absorption also is faster than the epidural.
Yeah, this is for medications. So we are at the moment talking about local anesthetic. Usually, yes, you're right. Local anesthetic will be absorbed from tracheal route as well. Okay. Okay. Anyways, so this is another point. And then if you like adjunct, we talked about bicarb, we talked about vasoconstrictor. Okay, then we add opioids. Okay, so opioids, we increase quality of block plus duration. Okay, so then another important point which we consider is the how to calculate the safe dose. So as I told you that it will be depending on the site where you are injecting, but usually it is 2 milligram per kg for bupivacaine, 2.5 milligram per kg of ropivacaine, and 3 to 5 milligram for lidocaine. And if it is with local anesthetic, it's with vasoconstrictor, it is with epinephrine. And if you are using it for topical airway anesthesia, it is up to even 9 milligram per kg. Okay. So this is the doses which you should be knowing. Okay. Then another thing.
Shan bhai, here I just want to add the pediatric dose here for airway. You shouldn't go more than 4 milligram per kilogram.
4
safety dose.
milligram per kg of lidocaine for,
Yeah, for airway. Let's say if you are doing microlaryngoscopy or if you want rigid bronchoscopy for the airway procedures.
Okay.
So we use 4 milligram per kilogram.
Okay, and here, if you can just tell the doses regarding epidural. Okay, we will come to that point as well. Up till now, anyone wants to add?
What about the liposuction dose in plastic surgery?
Liposuction.
Yeah.
Usually they put lidocaine, not bupivacaine.
No, lidocaine. Yes.
So
Lidocaine.
Again,
with epinephrine.
it will be coming in this category.
No, it's 55 milligram per kg. Up to.
55 milligram per kg.
Yes. Up to they can give.
Okay.
This is the maximum dose for the lidocaine.
Okay, and it will be according to lean body weight or
Sorry.
Lean body weight.
Yeah, but they first give, then this remove by the liposuction, and up to 55 milligram per kg they can infiltrate subcutaneously.
I think the
After
reason
that-
may be because they are doing suctioning at the same time, so
Suction,
maybe
yes.
it's not absorbing all, so
Yes. Yes,
so
yes.
maybe
That's why, but they give at it's definitely it will be detract also, but they give with this dose first, infiltrate, then they do the suction, and after that there is airway for dose, means for the fiber optic is 9 milligram per kg.
Yes. Okay. It is something new. I never read about it. Anyways, then another aspect which you should be knowing, that whether you are giving it for, like as I told you, for analgesia or anesthesia. Okay, so if you are giving for anesthesia, usually we are giving 0.5% of bupivacaine if you are giving for anesthesia. Okay, or 2% of lidocaine. Okay, and if you are using for analgesia, usually you require 0.0625 to 0.125, and you up to 0.25 you can give, but usually you can achieve at lower percentages as well. Okay, so another for the juniors, if you want to calculate how you can calculate that this is 0.25%, what does it mean? Whatever percentage is there, you multiply by 10, so it will become 2.5 milligram per ml. Okay, 2.5 milligram per ml. If it is 2%, it is 20 milligram per ml. If it is 0.5%, it is 5 milligram per ml. So that's how you will be calculating the dose. That if you have, for example, a 10 kg baby, so maximum you will, if you make it by 2 milligram per kg, so it will be 20 milligram maximum dose. Okay, so route will be different, and but maximum dose by any route will be not exceeding 20 milligram for bupivacaine. So if you calculate it, so it will be 4 ml. So 20 by 5 is equal to 4 ml. So you cannot may give more than 4 ml of 0.5%. Okay.
One more thing here, just for the pediatric,
yes,
I will add, Shanghai, is what you can do is easy way is, let's take the patient weight is 10 kilogram, then you can take 10 ml of 0.25%. So that will be always below the.
Yes, I'm sorry. Please say it again. I missed it. I was concentrated on something else. Yes, please say it again.
Let's say if in your practice you are not using Marcaine and you are using levobupivacaine or ropivacaine, the safety dose is 2.5 milligrams. So let's have a 10 kilogram child. You can technically give him 10 ml of 0.25%. up to.
Yes.
10 ml. So that's the easy way how we calculate it in
Yes,
practice.
yes, yes. You are
Right?
absolutely right.
So we just go by the weight of the patient, the same amount of ml we draw up from 0.5 to 5%. That makes our life very easy.
Yes, because levobupivacaine or ropivacaine, they are isomers and they are less cardiotoxic. Okay.
And babies are more prone to cardiotoxicity because they have less protein in the body as well as
Yes.
compared to adults. So, you shouldn't be using 2% mark in small neonates.
Perfect. Because another thing is that usually we are not giving any regional anesthesia for sole anesthetic. Usually more than 90% cases we are only giving for analgesia. Okay. So for analgesia, actually we don't need that much dose. Am I right? This is also one of the factor. Okay.
Yes, that's absolutely right.
Because another thing is that how we calculate the dose for Armitage regime, that's in the pediatric. In adult, that will usually we don't use it, but in pediatric that's the issue, that 0.25%, and it is according to 0.5 to 1.5 ml per kg according to whether it is like sacral or whether it is thoracic. Okay. So how to interpret it is that, like, for example, to baseline, if it is 10 kg and you have you reach up to lower thoracic or lumbar, so you are taking 1 ml per kg, so it will be 10 ml. Okay. So similarly, you are just touching the dose as you were telling. Okay. 2.5 if it is ropivacaine. Otherwise, you will take 8 ml maximum, and then you can dilute it. Okay, you will, if for example, if it is reaching, if you take 10 ml, it will be 25 milligram, and for 10 kg, it is exceeding the safe dose. So you will take this one 4 ml, and you will dilute it. Okay, because you don't have to cross the maximum dose. So 20 milligram is maximum dose. So if you are taking 0.5%, because you have to make it 0.25%. So 0.25% means 2.5 milligram per ml. So you will take it 8 mLs. You will not give more than 8 ml. Okay. That's what I wanted to tell. Or you can decrease the concentration. You can dilute it. Then Wes, if you can just tell the doses which you told me in the morning, you can regarding the spinal doses in the pediatric, but you were telling that 0.1 to 5%, am I right? 0.1 to 5%?
0.01%, sir.
0.01%? No, spinal, we are talking about spinal. Wes, are you here?
Yes, yes.
So you told me.
So the spinal dose, I'll tell you, depends what you are using.
Okay.
Let's say if you are using 0.5%.
Okay.
All right. So you can give up to 0.2 ml per kilo.
0.2 ml per kg. Okay. So if we just take an example of 10 kg as we are taking, so we will have 2 ml. So won't it be a higher one?
For spine, yeah. So or you could, that 0.2 ml per kilo of 0.5%. That's
then isn't this high?
It is 2 ml. 2 ml of 0.5% is 10 milligrams. So let's say for 10 kilogram, 10 milligram is not high because it's 1 milligram per kilo. So that does not exceed the toxic dose.
Okay. Okay.
And also just want to add, because it's also not a high dose, because in pediatric patient pediatric age, there is a higher dose because there is
they need a higher dose because they have more
CSF production and
Yes,
circulation.
four
Yes.
per kilo, yeah, as compared to 2 per kilo.
Yes.
Yes, you're right,
And
that point as well. And the only thing is the volume, we have to kind of restrict the volume because you have to see the size of the baby. The size of the baby is very, very small. So we are not worried about the dose. Dose is we have to put it under the safety dose, but we are more worried about the volume so that it doesn't go very high, because the spinal space, because the size is technically small of the child, so the space technically will be small as well, anatomically. So you have to keep that in mind, and you don't do a high spinal for the
So,
neonates. So that's
do
why
we-
volume is very important. So
Oh.
that's why we restrict the dosages to the volume. And that approximates usually to 1 milligram per kilogram of the Markin dose, which is kind of the safety dose.
Okay, so just my question, because in some part of world we have 0.75%. So is it because that volume will be less? So isn't that better? Because we can reduce the volume.
Yeah. So if you have 0.75%, then you can use 0.1 ml per kilo as well.
Sir, isn't it
But that
depend
will
on weight of
reduce
the?
the dose as well.
Anyway, I understand.
But Zishan bhai, just to finish this off, that will
Yes.
reduce your dose of Markin as well, because your dose of Markin will then become, instead of 1 milligram per kilo, 0.75 milligram per kilo. And the
Yes.
side effect of that will be that the duration of action, you're only getting 20 minutes anyway, and that will even become more less. So your surgeon has to be really fast, try to finish the surgery in 10 minutes. so practically I take the 0.5 option.
Okay. Yes, Talha, what you want to say? Talha, you raised the hand. You
Yes,
want
sir.
to
Yes,
say-
sir. Sir, yes, sir. Sir, in our practice, we are doing 0.5 mg per kg for children less than 5 kgs and 0.4
0.5?
mg per kg.
Again, please,
Sir,
0.5.
Sir, 0.5 mg per kg of 0.5% bupivacaine for neonates who are less than 0.5 for less than 5 mg 5 kgs, and for
It-
children 5 to
Just a second.
15.
Just
Sir.
let me clear. This you are saying 0.5 mg or 0.5 ml?
0.5 mg, 0.5
0.5
mg,
mg.
milligrams per kg.
So if it is
per
5, for
kg.
example, so it will be 2.5 milligram.
Yes, sir. And for children whose age is 5 to 15 kgs, we are using 0.4 mg per kg. And for children more than 15 kgs, we are using 0.3 mg per kg. And we are using the space of L4 and 5. And we have very good results of this spinal anesthesia in children. First, we sedate the patient, then we will give anesthesia, then we will apply spinal anesthesia, and its duration of action is almost 60 minutes to 90 minutes. It
And
has wonderful effects.
which needle are you
Sir,
using?
27 gauge spinal
And
needle.
is it special? How much is the length of the needle?
No, sir, it's the normal needle, but sir, it's because of experience, we will just insert in 3 centimeters, and in first attempt we are able to get the CSF.
Okay.
My
Space is
friend,
very important, sir. L4 and L5, not L2, 3, because spinal cord in children ends at lower levels.
Okay.
Zishan,
Yes.
Zishan, I just want to add a small comment here about the my friend here. If you don't mind me asking, what kind of surgeries do you perform? Like 15 kilo,
Sir,
I would
below-
imagine the child would be 3 to 5-year-old child. And
Sir-
what surgery are you doing spinal for in these children?
Sir, hernias, and lower limb surgeries.
And lower limb
For
surgery
example,
and
orthopedic
hernia.
surgery.
And
Yes, sir.
orthopedic.
Blue umbilical surgeries. Sir. All the blue umbilical surgeries we are doing it spinal anesthesia.
And you are working
and
at
you are giving GA as well to them.
No, sir. No, not G. Only sedation. First, we pre-medicate the patient with atropine and ketamine. Pre-medicate, and then we will give spinal, and after that, just only sedation, and we are able to proceed for the whole case.
And what's
It's
the
less than 60
advantage?
minutes.
What's the advantage over general anesthesia have you found by this technique?
Sir, we are working in not in tertiary care hospitals, so cost effectiveness And second is of COVID protocols. We are moving towards the regional anesthesia.
You are working at children
Because of-
hospital?
First of
Yes,
all,
sir.
let me tell you,
Sir.
my friend, I feel,
Sir,
I'm sorry
sir,
to say this, my friend, I'm sorry to say this, but this is totally an unethical practice. I'll tell you why. Because doing spinal in children, right? Children who are growing, alright? Children who are growing of age, and in this age group, subset age group, which you're talking about, and the reasons that you are doing the spinal cord, these are not justified as well, because this is not the standard practice anywhere in the world, my friend. That for
Sir,
her,
if you search it, there are many
No.
articles. There are many people who are doing this.
yes, but
It's safe.
you
It's safe
see,
anesthesia. It's not that much.
no, how just poking a needle in somebody is not safe at all, in my experience. And I think a lot of senior anesthetist colleague will tell you this point, that poking a needle in somebody's spine, in somebody's CSF, is not a very safe procedure to do in any sort or in any way. All right. And for a reason as small as a hernia in a 5-year-old child, I think this practice ethically is wrong.
No,
I'm happy.
I will,
I'm sure you are getting the satisfied results, that your child are pain-free and everything. But think about one complication that can ruin a child's life. That could never have happened if you had done GA.
okay.
So-
Just a
So
second.
there
I
are
will-
many complications of GA as malignant hyperthermia. It can occur.
No, I will, no, I will just be a moderator in this discussion. I will tell you something, that sometimes if you are telling that role of regional anesthesia as sole anesthetic technique, we are discussing this thing. Okay, so I will second to point raised by Awais in that way, that maybe with sedation, it's not safe, because if child airway can collapse. Okay, there are high chances of collapse of child airway. This is one reason. So in the exam, even if you are practicing it, if they are asking for like safe anesthesia technique, unfortunately you cannot say it, in my opinion. Okay, practically.
What we are doing, in my opinion, is that better safe practice
It's
is
wrong.
GA
It's
without.
wrong. Whoever is
Yeah.
teaching you this, my friend, or have started this, it is totally wrong.
No,
and
Awais,
unethical.
I can
Children
understand.
should
I
not
can
be
understand.
subjected to this kind of anesthesia for simple things like hernia. They are growing, and they still, their spinal cord is growing. If one thing goes wrong, their growth stops. All of their life they will suffer for this one small thing that other people said that it is safe. Think what you are going to do. Can I do this with a very simple technique? That's the best thing to do. Less invasive. That's the safest in the children. And any examiner, like Zishan Bhai said, if you go to any exam, definitely the only one thing they see is how safe are you. And doing spinal in children, I have never, as a pediatric anesthetist, I have never done a spinal in any child, and I don't intend to do so, because I'm not convinced yet.
I will tell you something just now, Talha. Just try to answer focused question. Just tell me one thing: if you do caudal versus spinal, what advantage you are getting? Yes, Talha. Only Talha, you answer. Talha, can you hear me?
Dose, sir. Sir, it's dose, sir. In a caudal, you are giving it too much dose, and in spinal, just 1 ml or less than 1 ml. You are
Okay,
getting the
this
same
is-
results and a good results.
Okay, so you are reducing the dose. This is one advantage. Okay, fine. Just tell
Sir.
me one thing: what advantage you are getting as a sole anesthetic technique for regional? Because when we give regional, we should have enough benefits over disadvantages. Okay. So if you try to explain this thing in exam, practically I agree to you 100%. Okay. Because things are different in Pakistan and other parts of world. So practically speaking, if you are doing it, 100% is correct. No problem. If you are doing it according to the circumstances you are telling. But in the exam, I will suggest you never ever quote this, even if you are doing it.
Yes, sir. You are right about it, sir.
Because this you cannot prove it. For regional in adults, you are blunting the stress response. You are decreasing the chances of DVT. You are this one embolism. You are having a post-operative analgesia. So there are so many reasons which you are giving regional anesthesia in adults. Okay, so it needs a lot of expertise. There are, as Avas mentioned, there are chances of neurological damage. And if you are doing a little bit of sedation, child will keep on moving. So sometimes it is very difficult to perform it, even if you are experienced. So there is always a chance of. So in
My
the exam,
last point, Jishan bhai, last point, coagulation. These children are sometimes undiagnosed. So many kids are undiagnosed, you know, and in children, sometimes it is very late that the disease is evident. So never underestimate that. You won't be able to catch every disease. So be careful.
Okay. So I think I will move on because we have a number of aspects to cover. So we were at the dose calculation. So in the dose, the other thing is concentration. So we have to, whenever we are choosing the doses of for any procedure, you have to calculate whether it is for analgesia and for anesthesia. As I told you, for anesthesia you need 0.5%, and analgesia you need up to less than 2.5%, 0.25%. Okay, so this is one thing. And then you have to calculate the safe toxic dose, and then you will calculate accordingly. So we can discuss about these things. Then what else? Actually, I just lost the focus. Yeah, what are the things we should be ruling out when you are performing? So one of them is a patient not on any anticoagulants and antiplatelets. Okay, and what else? You have to
sepsis also.
Sepsis. Okay, you have to. There should not be any deformity limiting the positioning which you want should be adequate. You should be able to make the proper positioning. And
Patient's cooperation is
before that, you have to counsel. You have to tell about all the procedure. You have to tell the common complications about it. Like, for example, you can tell that there will maybe hypotension, there may be some numbness you will be feeling, there may be paresthesia. Okay, even this is common for even
Cardiac diseases as well, Zishan bhai.
yes. Cardiac diseases, like any condition in which there is fixed cardiac output state.
You know this all.
And you don't allow sudden cardiovascular changes. So you, in that patient, especially the stenotic lean, okay, so you will not be giving spinal, because there will be sudden decrease in SVR and it can create problem. Okay, so this is okay. And now some help from the accessories which we use. One will be ultrasound, one will be nerve locator, okay, and the other will be anatomical landmarks. And there are some compartment blocks. Okay, so for ultrasound, and of course, if you are using it for any like compartment block or nerve block, if for spinal epidural central neuraxial block, you get the midline, the distance up to the space, okay, and the number of vertebra you are there. So focused, you can get 3 information which can help you in performing the central neuraxial block. Okay, midline, where is the midline? Distance from the skin to the space, okay, because there is skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum, and then dura mater. Okay, so these are the structure. And if you are giving paramedian, you will bypass these 2 things. Okay, so skin, skin subcutaneous tissue, and there will be paraspinous muscles, and then you reach ligamentum flavum, and then the dura mater. So that is the advantage of paramedian, that because there is less ligament injury theoretically, so there are less chances of ligament injury takes more time, because ligaments are relatively avascular, so their healing takes more time, so less chances of this transient backache which can occur after spinal. Okay, so this is some words about paramedian. Ultrasound, we use it, and for usually whenever we are giving any regional anesthesia, usually there is one vessel, usually in majority of cases where we are giving the peripheral nerve blocks, usually there are
Sir, just
vessels.
sorry for interruption. The other benefit of paramedian is also patient
less
positioning.
chance,
Yes.
yes, less chances of there are that there is less chances of PDPH, and less issues with the positioning, and another advantage in elderly patient, that there is sometimes ligaments are ossified, so it becomes very easy to reach the space. Okay, so these are the some more advantages of paramedian. Less ligament injury, less backache, less incidence of PDPH, and positioning issues are less, and in elderly patient it is helpful. Okay, so with the ultrasound, actually when we are using it, we are sometimes we are able to identify the vessel, okay, the artery and the vein. So usually, even if you are talking about supraclavicular or interscalene block or axillary block, there is accompanying vessel. So when you identify the vessel, then it becomes easier for you to first of all avoid the vessel, and then it will be helping you in getting the and sometimes with nerve locator, usually we start with because I have less experience of nerve stimulator, we start at 0.5, no, 2. How much current we start with? 2 milliampere?
1 to 2 milliampere, then gradually.
Actually, we calculate the supramaximal stimulus. Okay.
No need to fear.
I'm sorry. No, I'm sorry. The supramaximal is for nerve stimulation. Nerve stimulator, and the other one.
Someone start with 2, someone start with 1 milliampere, depends upon
and
the
then we decrease up to
gradually,
0.5. It should be coming at 0.5 milliampere. We decrease the point this volt, and it should be coming. And if it is coming even at 0.3, it means you are intraneural. So you need to withdraw the needle. Okay, you need to withdraw the needle.
No, 0.2 is the no option.
Anyways, 0.2 to 0.3. If it is very low voltage, if there are contractions are coming, so you need to slightly withdraw it. And then this will be helping. And sometimes people combine ultrasound, they identify the place and then they put the needle to have the correct needle location. They confirm it with the ultrasound plus the stimulation. Okay, so this is another thing. Then anatomical landmarks, of course, as I told you, that usually even with the palpation, they are palpating some artery and they are going lateral or medial or up or down. So this is another thing. In the compartment blocks, there are two things that with the ultrasound, they are checking the muscles or anything. Sometimes in some blocks, they are touching the bone and withdrawing. Okay, and with experience, who people are and for that, actually the TUI needle is being used. They check the anatomical pops, okay, to identify the space. These are different ways when you are getting it. Then what are the endpoints? So endpoints will be, for example, if you are giving central neuraxial block, there is autonomic block, there is sensory block, and there is motor block. Okay, if you are giving a peripheral nerve block and you are going to identify, you have specific contractions. Okay, specific contraction of the muscle group, which will be telling you this is true for upper limb blocks. It's like that. Or for example, in some cases, there may be, for example, if you give interscalene block, so there are chances of this Horner syndrome. It is also there with stellate ganglion block. Sympathetic block, it occurs, and Horner syndrome can occur. Also, there is phrenic nerve involvement. So there may be breathing difficulty. Okay. So this is how you will be getting the end results. Okay. So usually the complications which can occur immediately, one of them, before you poke it, the vasovagal syncope. So this is something common to any block. It can occur even with spinal epidural caudal, or it can occur with the peripheral nerve blocks as well. So vasovagal, you will have to lie down the patient, show the patient oxygen, foot up, and you might need to get atropine. Okay, so this is one of them. Even this occurs with local infiltration. Okay, so be ready for it. It is something, that's why we should be using insulin syringe to poke first, and then you can take 3 cc or 5 cc for the proper local infiltration. So this is an important thing. Then after giving spinal or epidural or any block, there may be sudden hypotension. Okay, while performing, there may be paresthesia. You have to tell the patient as well. You might injure the vessel, so there may be hematoma. Okay. Okay, so if you are in addition to 3 terminologies, we will just quickly, I will just try to discuss, because we have already taken a lot of time. Last, high spinal, total spinal. Okay, so last is the absorption and causing the this cardiovascular and CNS effects. Local anesthesia, systemic toxicity, that like more drug is being absorbed. Either it is absorbed very quickly or it is given directly into the vessel. So this is the most dangerous thing. There will be the main base ABC, and there will be need of intralipid. Okay. If you have given high spinal, there may be sudden, because there will be exaggerated sympathetic block, that the cardio acceleratory fibers T1 to T4 are blocked. So there is bradycardia and there is hypotension. Okay. And because of hypoperfusion, there may be transient apnea. But if you correct BP, the breathing will come back and patient will resume breathing. Okay. But if it is total spinal, there are cervical nerves are involved. So there will be apnea and you need to mechanically ventilate. So this is how to differentiate between total spinal and high spinal, that if you give high spinal and you correct immediately, you anticipate and you correct the blood pressure, the breathing will come back quickly. But if it is total spinal, patient will not be able to breathe till this local anesthetic is metabolized and the diaphragmatic function comes back. So this is the different, but usually general, they will be similar. There may be apnea, there may be hypoxia, there will be hypotension, there may be even cardiac arrest. Okay, if it is very severe, there, and the approach will be common approach, airway, breathing, circulation, supportive manner. Okay, and if there is paresthesia, you have to withdraw the needle slightly. Okay, and if there is, for example, bleeding, if you aspirate and there is bleeding, it is better to withdraw the needle and reinsert. Okay, or you can slightly withdraw. If it is case with epidural, you can slightly withdraw, and then if you make sure that it is not intravascular, or if you have any doubt, it is better to remove and reinsert. Okay, these are the common things which you should be knowing. There are certain formulas for the performance of this regional anesthesia, as maybe you've been needing sedation or angiolisis, you need nightling, you need I for IV, line. Okay, M for monitoring,
IV line, yes, before.
monitoring, R for resuscitation, A for assistance, and G for GA facility. There are so many things which you should be knowing about it. So like we talked about anticoagulation, sepsis, any contraindication, disease, and dosage calculation, percentages. There are some other adjuncts which we are using. One of them is dexamethasone. One of them is this dexmedetomidine. Okay, in addition to opioids, as I told you, dexamethasone is increasing the duration, especially with this one peripheral nerve blockade. Okay, this dexmedetomidine is also being used with even spinal, and it is increasing the duration of block. Okay. So these are the general aspect which I just
Zishan, I just want to add,
yes.
there was a very nice study that showed that dexamethasone given IV or given in the block.
Yes, it's the same IV
Yeah.
or in
There's
the
no point in giving it in the block anyway. So
yes. So another aspect which I just that in some of the blocks we can put a catheter. Okay, and then we can give it with the infusion pump. Usually for analgesia it may be differ, but usually it is 0.1% of bupivacaine with 2 mics per ml of fentanyl, and usually we are giving it between 5 to 15 ml per hour. This, if you remember, this is the common almost for an adult, whether it is epidural or whether it is through the peripheral nerve block catheter. Okay. Usually peripheral nerve block catheters are put at a place where there are less movement. Okay. So because otherwise there are chances of dislodgement of the catheter. I don't have experience of catheters, but people are doing it, and actually it's a wonderful way. Even there is a patient control epidural analgesia, in which there is a mechanism just like patient control analgesia. We are attaching it, and patient can give a bolus and control the rate. Okay. Any other aspect, the basic aspect which we want to have few words? Anyone wants to add something?
Sir, I wanted to ask that as you just mentioned that due to the injury to this interspinous ligament and supraspinous ligaments, patient may have this transient backache. So what is the duration of this transient backache? Like
There is no
sometimes
fixed
it's
rule. There is no fixed rule.
okay.
There is no fixed rule. But usually if you want to avoid this, that it is better to use paramedian. I am using since last my 18 year of my career, 90% spinal which I have given paramedian. I never give median.
Okay.
And I will suggest all of you to learn paramedian and never give a median, because in my opinion, there is no indication to do. Yes, what are the problems with paramedian? There are more chances of paresthesia, relatively more chances. There are relatively more chances of blood coming, okay, to injure any tiny vessels coming out. Similarly, there are, because nerves are coming out, so there are chances of, it can occur in midline as well, but there are relatively more chances. But this will not be a problematic thing. If you are using a small gauge needle, thin needle, then this will not be a problem. Okay. So I think we will just try to have some other topic. Most probably tomorrow evening I'm busy, so I will take a session at 3 p.m. Pakistan time. Okay, so I just try to give like an overview about the common things which we face while performing the regional anesthesia, related to safety, related to troubleshooting, related to basic local anesthetic knowledge which you should be knowing, and we just try to cover some of the aspects related to those. Yes, one thing, usually when we are giving, it is 1 to 2 ml per segment. 1 to 2 ml per segment. If you are giving for example, epidural, okay, if you are giving epidural and you want to, for example, you give epidural, labor epidural, for example, at say L2, L3, okay, and up to the first stage of labor, you need up to T10, okay. So how will you calculate? So you will calculate T10, 11, 12, L1, 2, 3, 4, 5, because whenever we are putting it, it is going 2 to 3 segments down and 2 to 3 segments up. So you have to calculate the down as well. Okay. So 1, 2, 3, 4, 5, 6, 7, 8. So if you just calculate it, it will 1 to 2 ml per segment. It will come up roughly around 10 to 20 ml. Different, a little bit different, but it will be around that one. So that's what I tell you, that if you want to just recall for adults, you will be roughly around 10 ml. Okay. So if you calculate like that, you will be there. Similarly, if you want to get epidural for this laparotomy, so you need up to level of T4. Okay. Up to T4 because of mesentery involvement. So that's how you have to calculate. That's why it is better to put it around T6 so that you are able to cover the area nicely. Because if you put it at lumbar and you are expecting, you want to throw it up till T4, number one, the dose requirement will be too high. Sorry?
Your screen is not visible.
I'm sorry?
Screen.
Yes, Talha?
Sir, no screen, sir.
Oh, thank you. Yes. You see, that's what I was telling you, that thanks for recalling. I forgot because I closed it. So if you are putting at L2, L3 and you are getting for labor epidural T10, as I told you, T10, 11, 12, L1, L2, L3, L4, L5, like that. Okay. So similarly, if you are calculating up to T4, you need a very higher dose. So that's why it is better to have T6, T7. So the dose you will be giving will be dose requirement will be relatively less, because the NCN, if it is from the level of this Zifi up to even umbilicus or even midline NCN, so even then it will be easier for you to cover. So that's how you calculate 1 to 2 ml per segment, and concentration will be 0.5% for sole anesthetic and 0.25% or lower. Usually in post-operative period, we give 0.1% to make it simple. Okay, if you want to prepare it, you will take 2 ml of 0.5%. It will be 10 milligram, and you will dilute it total in 10 ml. So it will 0.1%. Okay, so 0.1% means 1 milligram per ml. So 10 milligram in 10 ml. That's how you calculate the dose. And volume, I told you. Okay, so this aspect was missing. And another, in addition to the common thing, another is failure. I missed it. Failure, incomplete, patchy. Okay, and in addition to that, we discuss about hypotension, and we discuss about vasovagal, and we discuss about hematoma, we discuss about paresthesia. Okay, so these are the, for failure, you will consider to repeat it. Okay, if it is total failure. If it is incomplete, you may or may not consider to repeat it, or you will have to reduce the dose if you want to repeat it. This is where with regard to spinal. Okay, if it is patchy, you can augment it with some top up of anesthesia by parenteral route. You can give some sedation, you can give, so according to the situation, whether it is at the start or in the midway or the stage at which they will decide what you should be doing the troubleshooting. Okay, so thanks a lot. So we will have a session tomorrow. Most probably I will just try to have something else than our normal routine. Okay, so 3 p.m. Pakistan time. Thank you very much. Bye bye. Any questions? Thanks Awais for your presence. Thanks Jamil for your presence, because Awais is, by the way, in Ireland, and Jamil is my very dear, my buddy, my study partner, and recently he passed FCPS. So after passing FCPS, I really don't find people joining me. I think Jamil also is being caught in Corona, so he's in isolation. So I think that's why Jamil has joined. I hope to see Jamil continue to give some time to us. Okay, any questions? All of you are welcome to ask any question anytime. Okay, thank you.
No, sir. Only I just want to add, as you told about the epidural volume,
Yes.
there is 1/3 spreading of below the catheter and,
And
2/3
2/3
above
above.
that.
Yes, yes.
You just want to add that. The
Yes,
volume.
1/3. If you give 10 cc, 3 cc will go down and 6 cc will go up. Okay, it's
Then
like
you
that.
can calculate the segments.
Okay.
Thank you.
Okay, bye bye.
Thank you, sir.
It was a nice learning experience as well. Thank you.
Thank you, Awais.
Thank you, sir. Thank you.